Which glomerulopathy carries the highest risk of blood clots when it comes to nephrotic? Membranous. So we just said whenever somebody's got nephrotic syndrome, we only think about three important conditions: membranous, FSGS, minimal change disease. The global rule we spoke about was you're losing a lot of anticoagulants and you keep procoagulants uniquely, and your liver produces a lot of pro and anti, but you're peeing out the anti, so you're left with a lot of pro. But that's a universal philosophy for all three. Membranous, FSGS, minimal, they're all the same, right? So why does membranous still win the cake? Why does membranous be the one to cause the most amount of clots in comparison to the other two? Because membranous has two more additional features. Membranous, because of the autoimmune process that happens, it actually causes increased expression of tissue factor, also known as thromboplastin, which is required to activate your coagulation cascade. It also enhances binding of platelets to your fibrinogen. And therefore, because of these two additional features, membranous is the highest risk of forming blood clots. Okay? If somebody's got nephrotic syndrome and they have proteinuria, are you going to start them on anticoagulation because you know they're going to develop blood clots? Or you want to wait for them to develop a DVT, shoot it up to cause a PE, and then they die, and you're like, well, I should have started a blood thinner. You want to start them on blood thinner. What are you going to gauge? When would you start blood thinners? Do every nephrotic syndrome patient get blood thinners prophylactically? Let's put it this way. If somebody with nephrotic syndrome gets a DVT, PE, or renal vein thrombosis, or any abnormal thrombosis, we all understand we can anticoagulate, right? Here you can use DOACs and anticoagulate. My question is prophylaxis, before it has happened. It is not a straightforward, absolutely let's do it. It is something to consider. That's number one. Now, when would you consider is depending on your blood albumin. When your albumin is starting to drop, it tells you you're peeing out too much protein. So when your albumin drops below 2.9, and specifically when it drops below 2.2, your risk becomes really, really high.